Hey there, if you're working behind the pharmacy counter, you know that dysmenorrhea is one of the top reasons patients come to you for help. So today, we're going to break down everything you need to know to give them some really effective evidence-based advice.
Okay, let's kick this off with a number that really puts things into perspective. 15%. That's how many menstruating Canadians are literally knocked out for 1 to 3 days every single month because of this pain. We're not talking about a little cramping here. For so many people, this is a seriously debilitating condition that messes with their work, their school, their entire life.
And that's exactly where you come in. You're right there on the front lines. You're often the very first person, sometimes the only person, they're going to talk to about this. So the assessment you make and the advice you give can make a huge difference, right then and there. So, what do you really need to have in your back pocket to feel confident assessing the situation, recommending the right treatment, and, just as important, knowing when it's time to refer them to a doctor? Let's get into it.
First things first, we have to really get a handle on the condition, clinically speaking. But just as important is validating what the patient is going through. That's step one.
So at its simplest, dysmenorrhea is just pain that comes with the period. But here's the most critical distinction you have to make right away. Are we looking at primary dysmenorrhea, where there's no underlying disease, or is it secondary, which means the pain is actually a symptom of something else, like endometriosis? Seriously, figuring this out is the #1 goal of your initial chat. Everything, and I mean everything, from what you recommend, to your counseling points, to that decision to refer, it all hinges on making this distinction.
So let's look at how you can tell them apart. For primary dysmenorrhea, you're typically thinking of a younger patient. Maybe the pain started a year or two after her first period. The cause? It's all about prostaglandins. And the big clue for us, it usually responds really well to NSAIDs. Secondary, on the other hand, well, that can pop up at any age, it's tied to some kind of pelvic issue, and it often doesn't get much better with our first-line treatments.
And that brings us to a super important question. What are the specific red flags, the clues that should make you think, this might be secondary and this patient needs to see a physician?
Think of this as your mental checklist. Is the pain starting way before the period or lasting the entire time? Are they mentioning pain during intercourse or any unusual bleeding? And here's the big one for us at the counter. Have they tried NSAIDs the right way and gotten little or no relief? Any of these should set off alarm bells for a referral.
All right, now that we know how to spot those red flags, let's really dig into our first-line therapy. For the vast majority of your patients who have primary dysmenorrhea, NSAIDs are absolutely the gold standard.
Now, this is so important to remember. NSAIDs aren't just masking the pain. It's all about their mechanism. See, primary dysmenorrhea is caused by way too many prostaglandins, which make the uterus contract painfully. NSAIDs work by blocking the production of those prostaglandins. So you're not just treating the symptom, you're treating the cause. That's why they work so well in about 80% of cases.
But for them to work that well, your counseling is absolutely key. It's not about popping a pill when the pain is already at a 10. You got to tell them the 4 key steps. Start taking it right away the second they feel it coming on. Consider a loading dose to get ahead of the pain. Always take it with food. And finally, keep taking it on a regular schedule, not just when they feel pain, for the first 2 or 3 days. That proactive approach, it makes all the difference in the world.
And the fantastic news for your patients is that 2 of the best options are available right there, over the counter, no prescription needed. Ibuprofen and naproxen sodium are your go-tos, your workhorses. Really, the choice between them often just comes down to what the patient tolerates better and how often they want to take a pill. Naproxen's longer-lasting effect can be a real plus for some people because it means less frequent dosing.
Okay, but what about that other 20%? The ones who don't get relief with NSAIDs or maybe can't take them for some reason? Well, that's when we need to think about second-line therapies, and these are going to require a prescription. Hormonal contraceptives are a fantastic next step because they inhibit ovulation and thin out the uterine lining. They end up dramatically cutting down on prostaglandin production. And you've got lots of options here, from combined methods like the pill, patch, or ring, to progestion-only options like an IUS, the implant, or the injection.
But hold on. One of those options, the depomedroxyprogesterone injection, DMPA, it comes with a really specific counseling point that you absolutely need to be aware of, especially when you're talking to younger patients.
So the big concern with DMPA is its potential effect on bone mineral density. This is a huge deal for adolescents who are still building up their peak bone mass. This is where your counseling is vital. You need to talk about this risk and strongly recommend they get enough daily calcium, about 1,200 milligrams, and that they supplement with vitamin D, around 1,000 units a day.
And of course, our job doesn't stop with just recommending medications. There are a bunch of non-drug therapies that actually have good evidence behind them, and they can really empower patients to get more control over their symptoms.
You know, suggesting regular exercise all month long is a great start. For more targeted relief, high-frequency TENS units have shown some really good results. And hey, since we know smoking is a risk factor, talking about resources for smoking cessation can have benefits that go way beyond just helping their period pain.
Whew, okay, we've covered a ton of ground. So let's bring it all home and wrap up with a quick summary of the absolute most critical counseling points for your practice.
First, and I honestly can't say this enough, validate what they are telling you. Just acknowledging that their pain is real and it's significant, that builds trust instantly. And reassuring them that in most cases, this pain doesn't mean something is seriously wrong, that can relieve so much anxiety. Second, be super clear with your instructions. Don't just say, "Here, take this for pain." You've got to walk them through that 4-step method we talked about. This one piece of counseling can literally be the difference between a treatment that works and one that fails. And finally, the big one for patient safety, when do you refer? Remember, a proper trial of a therapy takes about 3 to 6 months. If a patient comes back and says it's still not working after that long, or if they have any of those red flag symptoms we talked about, it's time for a referral. Your role in spotting treatment failure is every bit as important as your role in starting treatment in the first place.